Good evening, everyone. My name is Brian Murphy. I'm the regional director for D.O.R.C. And we have a great group of panelists tonight to discuss their first 6 months of using Tissueblue. Briefly, I'm going to go over a little bit of the background on the product for you. Bring up the... So Tissueblue is the first and only approved ILM stain. It is a 0.025% brilliant blue G selective stain. It is FDA approved, pharmaceutical grade, and over 300,000 cases have been performed globally. It is supplied in a pre-filled syringe, so that helps alleviate some of the staff mixing requirements with other stains. It contains a 4% polyethylene glycol, so you'll see an increased density and better targeting and contrast of the ILM. Here's what your pre-filled syringe will look like. It comes in a box of 5.
We don't see your slide, sorry.
Oh, excuse me.
Yeah, no problem.
Let's see. How's that?
See it now.
Yeah, we see the first.
We'll see PowerPoint. Yeah, there is.
You got it now?
Yeah.
Zoom difficulties, right? So just to reiterate, if hopefully my audio was good, but Tissueblue is a 0.025% brilliant blue G selective stain of the ILM. It is FDA approved. It's pharmaceutical grade material, and over 350,000 cases worldwide have been performed. It's supplied in a pre-filled syringe, so this does help alleviate some of the staff mixing requirements that take place with other dyes. And the product contains a 4% polyethylene glycol for increased density and better targeting and contrast of the ILM. And here's an image of the Tissueblue syringe, and it comes in a box of 5. Anybody who attends tonight will have the ability to get a box of samples, assuming you haven't had the sampling.
Oh man, you misspelled my name.
Did I spell it wrong?
Yeah, there's no H in my first name.
Oh, well, I apologize. Well, let me go ahead and introduce our speakers since I'm having Zoom difficulties. We have Mitul Mehta, Clinical Associate Professor of Ophthalmology, Retina Division, the Fellowship Director, Vitreoretinal Surgery at Gavin Herbert Eye Institute at UC Irvine. Carl Danzig, Retina Specialist and Director of Retina Clinical Research at the Rand Eye Institute in Deerfield Beach, Florida, which is near Fort Lauderdale. He's the affiliate assistant professor as well at Florida Atlantic University. And our moderator, Arshad Khanani, Managing Partner and Director of Clinical Research at Sierra Eye Associates in Reno, Nevada, Director of Fellowship and Clinical Associate Professor, University of Nevada, Reno.
Thank you, Brian. Great overview, and I want to thank all of our friends and colleagues who are attending and taking out time from their family to learn about Tissueblue. And I want to thank Mitul and Carl for really helping us out and sharing their experience about Tissueblue. What we're going to do today is we're going to really have discussions, and I really encourage all the attendees to put questions in the chat box and continue the chat during the program. And if we cannot address it during the program, we'll address it at the end. And we want to make sure that we get done right on time at 6 p.m. PST. But we have several videos to show you today, and we also are going to have a great discussion. So I'm going to share my screen real quick here. Can you guys see it, Mitul and Carl?
Yep.
Okay, great. So what have you learned from 6 months of using Tissueblue? This is, the topic today. I've been using it since day one when it was approved. And, I've been waiting for it for years because, we really needed a dye. I was a compounded BBG user in the past for last 8 years. So first question for you, Mitul, here. What dye were you using for staining in the past, and why did you start using Tissueblue in your practice?
Yeah, for us, for ILM, we were using ICG primarily. We would use Kenalog or triamcinolone for epiretinal membranes for the most part. But if a patient had kind of a difficult epiretinal membrane, sometimes we would use Trypan-Blue, which I really didn't like using because you have to go to air because it doesn't sync. With ICG, we would mix it with D5W to make it sync also. And we switched to Tissueblue for safety primarily, because when you have patients who have a macular hole with the retinal detachment, or in my specific case, we do a lot of PVR cases at the university. I like to peel ILM if it's an immature PVR to try to get under the membrane. And I don't like using ILM in a detached retina, ICG in a detached retina to get to the ILM because it can pool underneath the macula and become very toxic. So that's the main reason why we switched to Tissueblue, and we were very happy with the results.
Carl, what are your take on that, and what were you using? And I know in fellowship we used a lot of ICG. When I transitioned from fellowship, I transitioned to compounded BBG right away. So I was using that for a long time. What were you using in your practice, and why did you switch to Tissueblue?
So when I started in practice after fellowship in 2011, I tried compounded BBG and had mixed results regarding the quality. So I switched back to ICG as we had done in fellowship. And I liked it, but it wasn't consistent. Still, you had the nurses and the staff having to compound it and then give it to you, and then you inject it. I'd have to clamp the infusion. Nevertheless, I switched because I wanted something not only safe, like Mitul said, I also want something that was consistent time and again. And I was curious to try something that's been, fairly established in Europe. I mean, it was been used there since 2010. So it has a long track record with 350,000 cases. And I wanted to try something now that was FDA approved here.
I think that makes sense. It's like, the barrier was we had compounded BBG, but the problem was for me that it was not consistent at all. Sometime you'll get lighter dye, sometime you'll get darker dye. And then also the logistics about compliance and, different regulations. So I think that's why in the US, most people were using ICG, but obviously it has its own headaches, and we're going to talk more about it. And so that's why I was waiting, for it. And when I heard that it's going to come, we jumped right on it. And, the pharmacist at the hospital thanked me. He's like, we were tired of, logging compounded product and its risk and liability. So as soon as it got approved, I work out of a hospital, and it just went directly, to purchase, and we haven't looked back since then. So tell me one of the key characteristics here. Carl, I'll go with you first, and I have a video to show that. The pooling effect of Tissueblue, the problem I had even with ICG, and some people use D5W and other things to settle it down or put it under air. The problem I had with compounded BBG was that it just wouldn't settle very well. And I know that for Tissueblue, there is PEG in there, which makes it settle better due to higher density and viscosity. So when you used it for the first time, Carl, a while ago, it's been 5-6 months. Tell us what you saw in terms of the pooling effect, and not have to worry about settling and restaining with the dye because it's not sitting on the macula.
Yeah, no problem, Arshad. This one's pretty easy. So the PEG, that's polyethylene glycol, that helps the dye actually settle down over the macula and the nerve. This is nice. I can inject this mid-vitreous cavity gently, and it just settles down nicely. It pulls together. It's non-dispersive. I don't have to turn off my infusion. I had been doing that before. And I let it stay there for anywhere between 30 and 60 seconds. And my infusion stays on the whole time, and I irrigate it out, and it comes out nicely too, and leaves a beautiful stain.
And what cannula do you use, Carl, to put the Tissueblue? And do you stay inside, or you come out the eye for 30 seconds and then you go remove it?
We'll put it on a 25 gauge needle. I mean, because I'm not injecting deep into the eye, just into the mid-vitreous. And I do come out because, I don't like to leave it there. And I I set our timer on our vitrectomy machine, and it counts for 30 or 45 seconds usually, and we irrigate it out without an issue.
Great. And I know we don't have videos from you because your recorder wasn't working, but Mitul, we have some of your videos, but tell us, what did you notice? For me personally, it was very different. I mean, I actually videotaped a case where I put compounded, not settling, and then I did Tissueblue, and there was a huge difference. I think it really makes your surgery efficient because obviously you're not drawing it from the wild. There's no recipe that nurses are looking for. You just take it, open it, as Brian showed. It comes preloaded in a pre-filled syringe, and you just go use it, and it just settles right away. So, what was your experience in terms of just settling and staining with Tissueblue?
Yeah, so for me, the same as Carl here. I personally use a 25 gauge needle as well. My fellows, we tend to have them use a soft cannula just because we want them to get used to putting that instrument in and out of the eye because it's kind of difficult to get a soft tip in through valves. So the more times they do that, the better practice they have at doing that. But for me, I don't care. I just stick the needle in there and it works a lot easier for me. And so you're going to see videos of my fellow, my excellent fellow who still needs a job doing some injections here. Peter Clark, he's a first year fellow, fantastic surgeon. And he can, do these procedures because he can see so well because it stains the macula. It just drops over the macula. And I think one of the important things to do in these cases, especially when there is ERM, and we'll kind of get into this in a little bit, is having a large enough area where the blue is sitting down. I like to cover the arcades. So make sure you're covering, if there is ERM as well as ILM does not have an ERM on it. And we'll go into this, but this pooling was very helpful because now I use Tissueblue for all my cases, although with macular work. I don't use trypan blue, which is what we were using before. I don't like going to air and then filling that back up with fluid again, especially if it's phakic, because then sometimes you get bubbles floating around and you don't want to hit the lens. And I write with fellows, and I really don't want them to hit the lens. And we gotta just make it simple, right?
No, I agree. I think the best thing about surgery is less steps, the better. Carl dinged a lot of lenses during fellowship when he was my junior fellow. So I learned from that, protect the lens, right, Carl? I'm just kidding. Carl is a fantastic.
I want to be like my senior fellow and do like him. So, yep, a lot of lenses. Pump.
No, no, you did great. So I think, Mitul, your point about I transitioned all to Tissueblue too. It's just convenient, easy, going to air and trying to figure out if it's stain or not. If I don't get a good stain, I felt like I don't have patience that Carl does, set a timer for 30, 60 seconds. I know it's not toxic. So it's not like ICG where you have to worry about, oh, did I put enough or it's too much? And I just restain if I, was in a hurry and took it out after 5-10 seconds. But to my surprise, most of the cases, even with a shorter time period, I think if you give it 30 seconds, I think that's more than enough. And I think, it stains really, really well. And one important thing you brought about ERMs and ILMs, and, we'll talk a little bit about negative staining, where you get staining of the ILM and the ERM, you don't get a stain. So it actually helps you identify the edge of it. So we'll have some videos. So let's run this first video. This just shows you the pooling effect for the audience that we were talking about. So look at how nicely it settles. Obviously, you can see some optic nerve pulsation there. It's one of my cases. Either we were not on IOP control or the IOP wasn't lower, but you can see that how nicely it settles straight in the macula. So you don't have to worry about using air. Just go in and drop it. And then because of the peg in there, it's going to stain right away. So let's go to the differences. So Carl, you said you were using ICG. So tell me about, for you and your staff, what are the key differences between Tissueblue and ICG usage and the staining you see? Obviously I've listed here the benefits of pre-mixed sterile syringe, as I said, and safety consideration, versus ICG. So tell us, are your staff happy, and what do you see as key differences? Because, for our audience, most of them are probably ICG users if they don't use Tissueblue. Why should they consider Tissueblue versus ICG?
Okay, so there are a couple of reasons. It's a great question, Arshad. As we see in the clinic, with our intravitreal injections, we're moving more and more towards pre-filled syringes. Who doesn't want a pre-filled syringe? And just think about it. In the clinic, when you have to draw off a vial and put on the needle, it doesn't take a lot of time, but when you get used to pre-filled syringe, you realize the fewer steps that you're taking and how much easier it is and smoother it is. Well, that's no different in the OR with your staff. Those nurses don't want to be doing extra steps. They don't want to have extra exposure to sharp objects. They want something that's grab and go, deliver to give to the doctor, and let the doctor administer it. There is a safety issue here. There's less incidence or less chance of any introduction of infection. It was low to begin with, even with ICG, but even so, the consistency of the dye, the nurses, if there's a diluted dye and the stain doesn't stain well, the nurse is thinking, well, did I not give a good enough dye? Sometimes the ICG would clump. I've never seen that with Tissueblue. It just goes smoothly in the eye and you irrigate it out, and it's consistent every time.
So consistency, ease of use, and of course safety too, right? Because we know we don't want to use too much ICG, obviously, because of the the toxicity that most of us have seen with it. Mitul, for you, what are the key differences? As you said, you were using a lot of ICG, and do your partners or your colleagues at the university, do they still use ICG, or they switched to Tissueblue after you started doing it?
Yeah, pretty much everybody's 100% Tissueblue now. I think there's a random case here and there where they might try to use ICG, but for the most part, we've gone to Tissueblue. It makes it a lot easier for the OR staff, because if they see membrane peel on the list of the case, they just grab it and it's just ready to go. It's in the room, and then it just makes it easier. They don't have to think about anything. And then when we were doing ICG, there's 5 of us, and we would have 6 different ways to mix the ICG, and it was kind of ridiculous. And then they'd ask every single time, and then I'd be just like, wait, so how much sterile water do I put it in again? And then I dilute that 1:4 in D5W, and it's 1:4, which is 20%, which is confusing because that's 1/5, and so people would get confused. So now it's just open it and put it on a needle. Yep. And there's also less bubbles. We'd always get bubbles whenever they were drawing up things, especially with the long cannulas for the soft tips. With the 25 gauge needle, stick it on there, just put a drop out of the eye, there's no more bubbles, you just inject it and you're good. Also, I was having, the clumping thing that Carl mentioned, that's a good point. We would get clumping, and when you get clumping, especially when you dilute it as much as you do, you can have patchy staining, and it makes you wonder if there was ERM over that area with ICG. But with the Tissueblue, it's because it's so even, you actually know what is actually ILM and what is ERM.
No, got it. I think that point about mixing you brought, because every time I went to the OR, there's a new traveler nurse or something. They're like, okay, what do I do? Where's the recipe? Do you want this doctor recipe? Do you want that doctor recipe? Because I was a compounded BBG guy, and if they didn't have compounded BBG, I'm like, just mix the ICG. And they're like, well, each one has his different, doctors different preferences with D5W and whatnot. So I think you bring a really good point. I think the consistency and the ease of use is really, really crucial here. And I think it saves you time, right? I think number one is it's more efficient surgery. Number two is safe for the patients, because, as Carl said, you're not like, somebody's trying to draw it and contaminate. And number three is, is the fact that you're not going to have errors. And I mean, I'm sure, ICG, most places are okay. They have a strict protocol, but I was always watching closely when they're mixing ICG, because I know that, it could be toxic. By the way, for the attendees, I see Estevari is also on now. I mean, please send chat comments, questions, anything we'll try to address during the program, but we'll also have some chatting at the end. So there was a question about the cost. We'll get to it at the end for sure. So this is a video that Christina Wang contributed, and when Mitul Mehta was her fellow, I'm just kidding, Mitul. It's a different Mehta. I think you're more senior than her. So Christina's fellow is doing this kit, and using Kenalog or Triessence, whatever they're using for peeling, initially the posterior hyaloid and some ERM, and then you can see they're using a needle like you, Carl, to inject the Tissueblue here. And you can see, again, it settles really, really well. And then, you know, you let it sit for 30 seconds or so, and then you just go in and you can see you have a great stain. And, you know, this was ERM case. You can actually see some ERM and some negative staining around it too. And you can see the edges of ILM. Part of them are already peeled. And you can see that the stain is super nice, that even Mitul Mehta as a fellow could do a great job here. Just messing with you, Mitul. So you can see that it's peeling really, really nice. So I think the bottom line is that it's a really cool and efficient stain. Works really well. Mitul, any comments about the video? Is Christina's fellow better than yours or no? That's the bigger question.
I'm never going to claim that anybody's fellows are better than mine.
Okay.
But you know, that obviously it's a great peel by the fellow here, and I like what they did here, because you know, I like to put triamcinolone in every time we do a vitrectomy, just to see where the vitreous is, make sure the hyaloid didn't split, because sometimes you'll get a schisis of the hyaloid, and leaving some of that down will help mark some of the ERM as well. And then when you put the Tissueblue on, it kind of gives you this edge of kind of a negative stain. It kind of highlights it, almost like marks it all out. It's like, this is where the ERM is, and outside of it is the ILM. And sometimes the ERM is hard to grab, and so you pick up ILM lateral to it or outside of that area and use the ILM to pick up the ERM at the same time. And so I like that. It makes it easier. And I like to peel ILM on my ERM cases most of the time, not all the time, but most of the time, especially if they have a lot of distortion and really bad vision, because that'll prevent the ERM from growing back a lot of the time. So
no, I do double peeling too. Mitul, I do double peeling too. So there's a couple of questions here. Let's address them now.
Sure.
So Mitul, first for you, a question from Roman. Does Tissueblue stain the vitreous to any degree more or less than ICG? So let's say you have a stuck posterior hyaloid. Do you put Tissueblue? Can you still see the edges? My actually experience is that it does. I mean, so if I try to avoid Kenalog. I used to use it in all my cases. Now I'm like, okay, let's be more efficient. So if I'm not sure, I've seen actually some staining, some pooling on top of the vitreous. What do you think? And then I'll get to Carl.
Yeah, I see it as pooling, but it doesn't actually stick to it.
Yeah.
So it kind
We
of
just stick to ILM. Absolutely correct.
So it doesn't really like stick to the vitreous. So I find that to be not really anything I even think about for the most part.
So just sits on it, you know, it will tell you if there's like PVD is not in use, and you can kind of see it, but yeah, it doesn't really stain it. Gita has a question. Carl, I want you to answer. Do you find that there's enough to restain if needed? My personal take has been there's more than enough, and I've used 3 or 4 times stains in some difficult PVR cases to stain ILM, and there's been enough. What is your experience?
Yeah, I've had no issues with the amount in the vial and needing to restain. I mean, if you need to restain 2 or 3 times total, fine. If you need to restain more than that, perhaps I've generally only restained once. So I've had no issues. It's restained nicely. I like the negative staining sometimes with the ERM, or how it like sits in the grooves of an ERM, and, you know, pretty deeply, and be able to identify that nicely. And then you restain the ILM, much like in this video. And it's nice, and there's plenty of dye, you know, left over.
So you said you only stain maximum twice. So you're trying to tell me you're a better surgeon than me, because I said sometime I've done 3 or 4 time restain.
Sometimes 3. If I'm doing a double peeling of, yeah, I might do it a 3rd time, maybe.
You're getting back at me for that lens comment that you dinged a lot of lens during fellowship, you know. I think you're trying to get back at me. So Mitul, another great question from Alexander. Does blue stain PVR well like ICG? Sometimes it feels like even stain vitreous. Can you guys speak to all the things you can stain that aren't ILM? So he's basically saying, you know, what is your experience in PVR using Tissueblue?
Yeah, so I find with PVR, it doesn't actually stain it as much as it kind of gets stuck in the folds of the PVR, which kind of identifies it, which is nice as well, but it really does stain the ILM around it. So, you know, I like to use it in those cases because we really don't want to get ICG underneath the retina and detached retina. But sometimes, you know, especially when it's immature PVR, it's not pigmented, you don't really know where it is. other than where the folds are, and you kind of just blindly are picking at stuff. So if you kind of spray it with Tissueblue, it'll kind of negative stain it. But again, like an ERM, it'll kind of hide in the crevices of the PVR. So it kind of helps you identify that. So I like that.
Well, great segue, Mitul. So this is for Carl. You kind of mentioned it. How did you adapt to Tissueblue selective staining of ILM? And do you find negative contrast with ERM helpful? So, a lot of our colleagues say, well, it doesn't stain really well. Dimos here has a comment, in ERM cases, do you always restain to visualize the ILM? So Carl, tell me about your negative contrast with ERM. Is it being helpful? And do you restain to visualize the ILM?
So yes, to all of the above. So I do use Tissueblue exclusively when doing an ERM. It does stain negatively. I like how, because of the polyethylene glycol, it sinks down and it gets into the grooves of the ERM, and you can see it nicely. Even though it negative stains, you can kind of see the ripples of it and of the pucker. Then I always go back and I restain, because sometimes, when you do peel the ERM, sometimes some ILM comes with it, but by necessity, there's going to be some left over. So I restain with that, and I then peel with my ILM forceps, and haven't had an issue at all.
Yeah, so I do double peel too, just like you and Mitul. I think what I've seen is, the data doesn't support any better visual outcomes, but I think recurrence rate has dropped significantly. Before, when I didn't use double, staining, my recurrence rate was about 5 to 10%. And then, now it's close to 0. So I think that's a very good thing using Tissueblue. I do exactly what you said, Carl. I kind of stain it, negatively stain, get the ERM off, restain, and then get the ILM off, and then I'm satisfied that I got a really good peel. There is a question from Nadeem here. I previously tried compounded BBG, but wasn't excited about the quality of the stain. Is the stain consistently better with this versus compounded? I think that's an excellent question, Nadeem. So I'll tell you my experience. I was using compounded BBG, and initially when I switched from ICG, it was terrible, the 0.025%. And it was so much variability. I'm like, I'm not going to use it. And then because of nurses and ICG mixing issues, I said, okay, let me go back to it. So I called the pharmacy, and I actually was, because compounded, they can compound higher. So I said, double up the concentration to 0.05. And we actually, presented that data at ARVO this year, and it was safe. But when we got the Tissueblue approved, I know that the concentration of it was half of what I was using. And my concern was, is it going to stain as good as compounded BBG, which was double the concentration. But I've been pleasantly surprised how good it has been staining, even at 0.025. I think the key is to make sure that, you give 30 seconds. If you're a good surgeon, if you're like Carl, 1 minute, you need to see that.
Terrible.
I'm going to get some angry text after this webinar, Mitul, and I'll just ignore them. So 30 seconds, and I think it has done a really good job for me, Nadeem. So I think I highly recommend, D.O.R.C is going to send, as Brian said, samples, whoever is attending, and please try it and, be patient, 30 seconds, and that's all that you need. Dave Eichenbaum, our good friend, has a question. He says, what do you tell an ICG user is the best reason to change to Tissueblue? So I would, that's a really good question. Mitul, what is your answer to that?
So for me, it's the quality of the stain, especially in somebody who's got a darkly pigmented RPE. You get a bit of contrast, in my opinion, with the blue over the green. In a blonde fundus, both of them stain pretty well. We all did, tons of cases on ICG. But with the blue, it's just, I feel like it's a lot easier. I don't use a contact lens to peel. I use the green lens on the Resite. And so for me, like, there's a difference in depth perception and being able to see where the ILM is with these different stains. And with the blue, I think it's a lot easier for me to tell how deep it is, and so I don't get deep grabs. I have my fellows use a membrane scraper, but I pinch and peel myself. And I tend to, not have a problem with it.
Great, Mitchell. So your fellows use a scraper because their teacher is not good enough. Is that why?
You know, you must crawl before you run, right?
I'm just kidding. No, that's a good point. And Carl, you want to comment again about the fact that you were talking, and I think you mentioned it, just summarize for Dave Eichenbaum. Like, so Mitchell gave staining reasons. What are your logistics, safety, and other conveniences that you have at Tissueblue?
I think it all comes down to safety and consistency here. You know, safety for the staff, ease for the staff, fewer steps, the fewer opportunities to introduce random, adverse events. So when you have that, and then you have a safe product, especially if you're peeling with a MAC hole RD or in PVR and you're worried about dye getting under the retina, or a phototoxic effect. I'm not worried at all about this. It just puts my mind at ease. I'm not worried about, is this patient going to have a problem if the ICG leaks into the hole? No, this is a safe product, and I've had good success with it.
And then you mentioned about the European experience, right? When you have a new product in the market after all the anti-VEGF issues lately we have had with inflammation, people are nervous about using a new product. And Carl, you and I were talking about it, and you said, well, because of the European experience, you felt very comfortable with the safety. Tell us a little bit about that.
Right. So if someone asks me like, hey, I'm just nervous. We see something that gets FDA approved or something that doesn't get FDA approved, and we're worried about inflammation. It's a hot topic now for good reason in the retina community. And then they say, well, this, staining dye was approved in December 2019. I'm hesitant to implement it in my armamentarium in the operating room just because I'm worried about safety. So I actually did a little more research about this, and I looked at, well, it's been used since 2010 with 350,000 uses. So there's a long track record. So that was approved in 2010. There was trials before that, and then it got approved here in 2019. So I think we have a long track record, longer ex-US, obviously, but it's something that we can draw upon because we know that there are great retina surgeons all over the world. And I don't believe that they would use something, willy-nilly if they thought that it wasn't safe.
So Carl, to follow up, you are in a private practice and you go to an ASC. I'm in private practice, I go to a hospital, and Mittul is in university setting. So we're gonna get to that later. There's a question about have you used in the ASC setting from Henry. So Henry, just hold tight. I'm gonna run a couple more videos before we get to that, but I think that's an excellent question. So Mittul, this is your video, right? Your fellow?
Yes.
Okay, so go ahead and tell us what's happening here.
So this is a case that had an ERM as well as ILM to be stained here. And so they start with triamcinolone to stain the vitreous and make sure the PVD is up. And you saw the scraping a little bit there of the edge of the ERM and ILM at the same time with the membrane scraper there. And what that does is it kind of gets an edge of the ILM up as well. So that when you stain, it actually stains both sides of the ILM, and it gives you kind of a more obvious edge. And that's a little trick that I have my fellows use. And sometimes they need to continue to use the scraper to really get the edge up before they feel comfortable grabbing it, which is fine. And you can see right here in the video how clearly the stain is from the edge there. You can see how there's a relatively darkly pigmented patient, and you can clearly see where the blue is stained and where it's already been peeled off with this. We're using, in this case, Eckhart forceps to start the edge of the ILM. And it's combined ILM-ERM peel right here. And so if you can do that and grab both of them at the same time, because the edge is up of the ERM and the ILM, when you stain it, you stain the back of the ILM also. So you're peeling them both at the same time. So then now you see this peel with one peel able to peel both ILM and ERM at the same time here. You can, because you can see the blue on the peel that you're pulling up, as well as there in the inferior macula there, you can see the ILM being pulled up as well, right at the edge of the arcade there. So now you've peeled ILM as well as ERM in this case here. With one thing, you don't have to go back in to restain, and you're done.
That's great video, Mittul. Is it your first year or second year fellow?
That one was my second year fellow.
All right, they're hired, man. They're hired.
He's joining Tulane. He already has a job.
Okay, great. All right, we'll look for the next one. That was excellent case. There's a question from Dimos here. In cases of difficult ILM, restaining with ICG supposedly helps ILM detachment. What is the case with Tissueblue? Mitul, you want to address that because you teach a lot of fellows? And have you seen, I mean, people talk about it, you know, I think it's a theoretical thing. I never had a case where I felt like, okay, I'm using compounded BBG in the past or now Tissueblue, FDA approved. And I said, oh, let me go to ICG because this is a difficult ILM case. So tell me your experience and then follow Carl, you can follow him.
Yeah, I don't feel that it actually helps the ILM come up with ICG, because I did a lot of cases with ICG. I did all my cases in fellowship, and my cases for the first several years of practice here with ICG. And I would often restain for the reason I just mentioned, that once you have an edge, having stain on the back of the ILM makes it more obvious where the ILM is and what peels up. So I would do that with ICG, but I'd always be worried about toxicity, because now I'm putting even more ICG in the eye. And it kind of roughed up retina, because I would have started at edge, it would have peeled or used a membrane scraper. So with Tissueblue, if you do restain to get both sides of the flap stained to make it more obvious, you can do that safely. But I don't think either of them really, I haven't noticed any difference in terms of its actual effect on peeling itself.
Carl?
Yeah, I'm the same way. I didn't have so much of an issue with ICG in doing that. I don't switch once I use Tissueblue to reintroduce ICG into the eye. I find that if I use a membrane scraper, then I can find an edge and then restain with Tissueblue, and it works out nicely there. So again, I find that the ILM comes up pretty much equal between both. I never found that ICG was a better, agent at finding an edge for a difficult ILM. So I've been happy with both in that regard, but I like the safety of Tissueblue.
So I think your point being that there's a perception about ICG helping you, and Nadeem, put a comment that there was talk in the past about how ICG improve ILM tension and pliability. Does BBG have the same effect? And again, I've not used ICG for like 10 years now. So, I mean, from what I understand from both of you, the fact that it's pretty similar with Tissueblue, and you don't have to say, okay, Tissueblue is not working, let me go back to ICG. Have you guys ever had to do that in the last 6 months?
No.
Okay, great. So this is, you can see the quality here is pretty crappy. So it's made in Reno at a hospital with a really poor camera, but we'll live with it. So, here's a case of ERM and ILM. So look at the negative staining temporally. See that? So you see the BB, I mean, the video is not clear, but I got a stain. It's a pretty thick ERM, and I got the stain temporally. And then I actually go attack that area, and then I'm able to, peel the whole ERM from that. So, people comment that, hey, it doesn't stain very well. Well, look for that ERM. I mean, this was pretty dense one. You see it even without OCT, but, obviously I look on OCT before I go do the surgery, but you can see that it's a pretty thick one. And I was able to use the negative staining on the edge. And then I was able to peel this off, and it was pretty significant, and it came out nicely. And then, I will restain to look for the ILM. But again, the quality, again, made in Reno, Nevada, not in Orange County with high definition Mitul Mehta videos. So that's why the video is not great. But I think I wanted to pass the point that, and then you can see, as Carl said, some of the ILM was already up, and and then I was able to peel the rest of it with staining it. And again, I was not super patient, as you can tell. I just use a quick 10-second stain, and I was able, it's not super dark, but you can easily see the margins and able to really remove the ILM very efficiently after ERM removal. Any comments from you, Carl? I know you would have done better and quicker than me because you're a super surgeon, but the negative staining, I think it's a really good thing. And some people don't like it, like I've seen people say, well, it's not staining well, look for that ERM, look for the negative staining. And Mitchell made that point earlier that a broad area of staining is much better, because then you can see the negative staining much nicely. So I really love it for my ERM cases. So let's go to the next question here is, and there is a question from Jonathan about recurrent or large macular holes and advantage of Tissueblue. But what's your experience, Carl, let's start with you, with ILM staining during macular hole surgery? Do you have to stain once, twice? How easy it is if you're doing a flap? Is that good enough stain that you can do a taco or whatever you want to do in a chronic large hole?
So my experience with macular hole surgery, I actually used it yesterday for a small macular hole. So it was a pretty straightforward case. I stained once. I usually do restain, in all honesty, but I was pretty confident I got the ILM. It was circumferentially around the hole, easily peeled. I feel that with Tissueblue, if you were going to use a flap or like the taco approach, you can do that with this. I mean, it works fine. Before I used Tissueblue, it worked fine with ICG. It works fine now. I don't see as much of a difference, but obviously operating on chronic large holes or re-ops are challenging, regardless of the dye. And obviously it's a anatomic issue at that point, and we try our best. So Tissueblue works great at identifying any residual ILM that you can use for that flap.
Great. Mitul, this is your case, I believe. So tell us about your other fellow or the same fellow doing the case. And you're pretty close to the macula there. And I know Carl made that comment when we were reviewing the video. Are you okay with that, or?
Yeah, this was before a fellow who shall remain nameless may have had a complication from being too close to the macula during their injections. Okay. But this was, again, using the soft tip and trying to not.
Beautiful stain, by the way. Great job. Did you stain it only once?
Stained only once, but 45 seconds this time.
Nice.
So if you do
you're better than Carl. He does 1 minute, you do 45 seconds. I get it. Perfect.
Yeah, well, like 45 seconds, a minute. How long does it really take? We actually do clamp the infusion.
Oh, you do clamp the infusion. Okay. And do you put a timer too, or you just kind of count in your fellow is counting loudly?
I just look at the clock on the wall. And so, it's pretty, it's not exact science, right? So, but it works. It works. And this is nice. Like you can easily see the edge of the ERM as well as the ILM on the macular hole. And we like to, around the edges of the hole, kind of like scrape it with the Tano scraper just to make sure there's no ring on the edge of the hole, just to break that tension. And that's nicely. We didn't do a whole lot of the ILM flaps. We didn't do those in my fellowship. And, sometimes we'll do those on the primary case, but usually I don't on the primary case. And so on a secondary case, if it's a recurrent macular hole or a chronic macular hole, then maybe I'll put an ILM flap or even a blood patch over the macular hole if it's really big. That tends to make the hole smaller, but it doesn't, ever close the hole. The blood doesn't. But it does help. And, having the blue, you can easily see it when you flip it over, and you can see it over the macular hole, which is nice.
No, I agree. I mean, beautiful stain and a beautiful case. I don't really use primary flaps either. Like Mitul, when you and I trained, there were no flaps done, remember? That's why we're not trained on it. This is relatively within the past 5 years or so. And we have great surgeons, in attendee, I know Ash Tiwari's here, and, Tamir Mahmood, and those guys start pushing for newer techniques for the holes. But yeah, I don't use it for primary. Carl, do you use flaps for your primary Mac hole repairs?
No.
Yeah. Unless it's a bad large hole, it's not going to close then. But that was a great video, Mitul. So this is a video from Christina too. And, you can see here, she's using, triamcinolone and then inducing a PVD. And then you're going to, and see the quality is much better in Baylor than it's in Reno, You can tell the beautiful video quality here. And in Houston, and you can see that she's just like Carl. I mean, like your fellow, actually, Mitul, she's going pretty close. And like Carl, she's using a needle. And then, great settling because of the peg. You can see you don't have to worry about, am I going to get a stain? It's more about letting it sit for 30, 45 seconds to a minute max. If you sit for a minute, I think is going to be a really good stain. And then you can see here, she's removing it, and you can see the staining. And then what I like is a whole case, and I don't have to worry about ICG going into the hole, and then those crystals not dissolve and trying to cause toxicity or going there. So I think it's safety is crucial here, and she does a nice flap, and you can see this is a relatively blonde, light fundus, and you can see the really good good stain. So this is key here. When people talk about, ICG may stain better, well, look, compare. She put both of them next to each other, and you can see ICG, you had to use D5W, and then she did it under fluid for 60 seconds and didn't get a great stain, and then under 90 seconds, obviously it's a different patient, but you can see that it's so different in terms of Tissueblue is doing great. So when people say, well, it doesn't stain very well, I have to, because I don't use ICG much or didn't use it for last year, I can argue, but when I look at this, I think the stain is very good, and you're getting the safety and convenience. So let's go to the next question. And this is going to go back to Henry's questions about ASC. So Carl, I'm going to ask you first. You're working in ASC, cost is an issue. People always say, well, in ASC, and I've never been to one. So they say, well, you don't get a laser probe. You have to do indirect laser. If you use silicone oil, that's your last case there. If you use perfluoron, it better be your mother, things like that. So like they're cost cutting things, at ASC. So how were you able to implement Tissueblue, and tell us a little bit about pricing question came in and differences, and why should somebody at ASC consider Tissueblue from your standpoint?
Okay, a lot of great questions here, Arshad. So I do work in ASC, and I would say we're fairly well equipped. It's in our building where we have an ASC on the first floor and offices on the second and third floors. Anyway, the cost of the ICG was 6 vials for about $595 ballpark, whereas Tissueblue was 5 vials for $700. So Tissueblue comes out to about $140 a vial versus about $100 with all the needles and everything for the ICG. So you're talking about a $40 difference per unit. What I find and what I found is that to get something on board, if people are questioning, well, how do I get something more expensive onto formulary at my ASC, it's important to get everyone involved. So I first started using this, I got a sample box from D.O.R.C. Once we started implementing Tissueblue and the whole staff realized that, hey, this is seamless, this is safe, this is less responsibility holding needles and mixing stuff and having a correct dilution. Things are, repetitive and consistent by just handing the doctor the medication and it stains nicely. All the staff was on board. It saved time, it demonstrated safety. And when you have comfortable nurses, and yes, they're comfortable mixing the ICG, but much like Mitul said, or you said, Arshad, is, well, what's the cocktail of the day on how to mix the ICG? That's not the case here. So it's just one less thing for people to worry about. Is there going to be clumping? What's the stain going to be like? So when we used our samples, we were able to have an opportunity for 5 cases to really get a good grasp of like, what is different about this dye? Like what's different about this experience? And it was a no-brainer at that point because, everyone in the ASC who works with me was, and I'm the only retina specialist, so it wasn't like there's much competition there, but everyone was on board. They realized that we don't want to work with more needles. We don't want to be responsible for mixing a dye that may not have the dilution and quality that I want. So the extra $40 per case, for everyone's peace of mind was worth it for us.
I think those are great points, Carl. I think the key you mentioned is efficiency and safety of the patient. And I'm sure any ASC looking at that, a minute in the OR costs a lot of money. So if if somebody is spending an extra minute or 2 minutes mixing it, and then of course, safety is crucial, right? I mean, you don't want to have any errors and whatnot. So I think that price difference to me is minimal. I'm surprised how expensive ICG is compared to, I mean, BBG it's FDA approved and whatnot. And so, and it comes in a pre-filled syringe. The other thing is the expiration date, right, Carl? Like it has a 1-year expiration date. So if you buy it, like my hospital used to buy compounded BBG every 2 weeks because that would expire. And then they're like, wow, I'm so happy I can just order a big, order, and then I don't have to worry about it because the expiration is 1 year. So for my hospital, I mean, hospitals like to spend money. So it was like a no-brainer. They've been waiting. They're like, when is this thing you said is going to get approved? It's 2018, it's 2019. I'm like, it's coming, and finally did. And they just ordered a bunch of it. And all the there's 4 retina specialists that work, they all adapted to it like this. They were, ICG, or they were compounded BBG, and right there, they're able to totally do it because it's a safe option that's convenient for the staff, is good for the, safety of the patients. And so Mitul, you're at the university setting. I know we have 4 minutes left. How were you? University is usually the last one, you show up last to the party when everything is done. So how were you able to come during the party was on, like early on with BB Tissueblue? So what did you do?
Well, it was actually relatively easy for us. Like they did ask us questions about money, but there was a shortage of ICG at one point, and the university policy is because they bill the patient for every medication they use in the operating room, we could only use 1 vial of ICG per patient. We couldn't reuse it for multiple patients that day. So it was relatively negligible in terms of a cost difference as far as the university is concerned. The OR staff really liked how easy it was, and so they didn't have to think about it, because then they weren't getting yelled at by doctors, not me, but other doctors may or may not have yelled at the OR staff for mixing it wrong and it being wrong. And one time, this actually happened to me when I was in New York with ICG. They mixed it with D50 instead of D5W. And as soon as it came out of my syringe, it hit the retina, and the retina turned chalk white. It was scary because D50 is such a high osmolality, just sucked all the water out of the retina, and that was not a good thing. So that's one less thing you have to worry about, and that scarred me for life, I'm pretty sure. But it was just one of those things I was worried about. It's just the one less thing to think about. It's just like opening up Helon for a cataract surgeon. They just open it up on the table, you're good to go. It's just pretty straightforward. And so when the pharmacy, they ask, well, you can get this compounded blue from this other supplier. And I'm like, well, that supplier lost their privileges in California right now. So now they don't ship to California. So now you have to find another supplier. And then also we didn't like that one. So we were using ICG anyway, because we didn't like the stain we were getting with the compounded BBG.
Right.
So all these things, and the pharmacy just didn't want to deal with this anymore. And I'm like, if you just ordered this, like, we'll take care of it. It'll get shipped right to the OR. It doesn't even go to the pharmacy. And we'll just put it in the Pyxis. And they're like, oh, okay, done.
Yeah, no. I mean, at one of the hospitals here, they never buy anything. It takes them 2 years or 3 years because they're like so lazy and they put roadblocks. When second hospital I go to, when Tissueblue came out, it was in the Pyxis in 2 weeks. They're like, thank God we don't have to deal with your compounded BBG and whatnot. So this scarred for life comment is there. I'm scarred for life because I was doing 2 cases. I think it was, I don't know if it was you, Carl, but I was doing cases at a hospital, and I couldn't blame Carl for this one. What happened was I turned the infusion on in a diabetic phakic patient, and the lens turned white. And I'm like, what the hell? I'm like, Carl is not operating, it's me. I can't blame him, and he's not even here. So then I'm like, okay, I must have, maybe the infusion touched or my trocar touched. I do a second case and same thing happens. And I'm like, what the hell? So you know how we put D50 for diabetics in the bottle? They were actually using, I think it's like what, 4 or 5 ml. They're using 10 times more. So again, so I lost 2 lenses and I couldn't blame anybody for it but myself. So I talked to the nurse, and again, bad stuff can happen. I'm scarred for life. So that's why I really didn't like this ICG idea either. Mixing, there's always problems. So I watch when they do the ICG, but again, I didn't use it much because of the compounded nature. So I think it's 6 o'clock. We are able to address. Geeta has the last question. She said, "Are you able to take up the dye directly from the syringe with Vitrector?" I'm not sure what she means. So, it comes in a syringe and we inject it with a cannula and then we aspirate with the Vitrector.
I think what she's saying is, because what some people do is they'll aspirate it with the Vitrector
And
and
then
then
they
they'll
shoot.
reflux it into the eye.
Got it. Yeah. See, you're a better surgeon than me.
Yeah,
That's what she
I've
said.
seen people do that. I don't do that. Yeah, Geeta says yes. So I don't do that. I just have them put it on a 25 gauge needle and I just stab it into the eye.
Yeah. I've not tried it, Geeta. Next time I'll try it and I'll text you and let you know. So I think we took most of the questions. I really want to thank the participants for their robust, great questions. I want to thank Mitul and Carl for their expertise and great overview of their usage. I want to thank Brian, James, and all the team from D.O.R.C for allowing us to do this webinar to educate our friends and colleagues about Tissueblue. I know we're over time. Any 30-second closing remarks from you, Mitul, followed by Carl?
No, just, like if you haven't had a chance to reach out to D.O.R.C or when you signed up for the thing, you forgot to sign up for the sample, just reach out to these guys and they'll ship you a sample of the Tissueblue. And Geeta, I'll try your method tomorrow and I'll text you what happens. Okay.
Great. And Carl?
Yeah, thanks for having me here, everybody. Been a really great experience. In general, I've, been able to implement this through the sample program. And I found that it's a very easy, safe dye to use that gives consistent results. I think the results are at least as good, if not superior to ICG. And, I have not been disappointed.
And I want to thank Mike Pepin too. He's here. Brian, is that your boss?
He is, yes.
Okay. Yeah. So thank Mike for doing this, because without your support, nothing would have been possible. Brian and Mike, any closing comments? I know we're over time. So
Yeah, no, gentlemen, thanks. Great job, first class. Also to all the attendees, the questions were so great. So, real world, what's going on in the OR. So we really appreciate the participation, and to kind of build off of what was said, please reach out if you didn't get a chance to sign up for a sample, and we'd happily provide that to you. And then look for your feedback in the future on it. So thank you.
great. Anything
Thanks,
from you,
everybody.
Mike?
Thank you, panelists. Thank you, attendees. Great event.
Thank you so much. Have a good evening, everybody. Bye-bye.
Bye-bye.
Bye.
Bye.